Mayo Clinic presents
Emergency Medicine Grand Rounds.
Welcome to the September Grand Rounds episode from the Always On EM podcast, a podcast about emergency medicine from Mayo Clinic. My name is Venk Bellamkonda. I am one of the hosts of the show, and my co-host Alex Finch and I are thrilled to have you joining us. Before we move forward, we want to give a special thank you to the many of you who have subscribed to our show recently, and a few special folks have taken the time to write out reviews on Apple Podcasts. In particular, thank you to Grace F816 and to Missoula Mommy. If you haven't taken the time to subscribe or follow our show or write a review like these two, please take a moment while you're listening to do this. It really helps promote our show on the various algorithms used by the platforms like Apple and Spotify, and it helps put our show in front of potentially interested listeners. Alex and I are so grateful every time. You have no idea how excited we are when we see a review or a new subscriber show up. If you do this, you can definitely go to bed knowing that you have made our lives better. And what better measure of a successful day is there? Well, truthfully, I can think of one other measure. That is to hear and learn from our Grand Rounds presenter today. I have the incredible honor of introducing Dr. Alex Niven as our Mayo Clinic Emergency Medicine Grand Rounds speaker for this show. He is one of the many colleagues we have here who I admire greatly for their clinical acumen and their drive to help uplift the health and well-being of the community we live in. Dr. Niven was a born educator from his DNA outward, and he teaches others at work and outside these halls every single day. He received his medical degree from Tufts University in Boston and then completed internal medicine residency and pulmonology and critical care fellowship at Walter Reed Army Medical Center in Washington, D.C. He serves as education chairperson for the critical care group at Mayo Clinic and also for the Division of Pulmonology and Critical Care Medicine, co-director for the Pulmonary Function Lab, and is a professor of medicine. His record of honors and recognitions is incredibly long. Among them, he has been recognized as Teacher of the Year by the Mayo Clinic Fellows Association, been nominated for the Hall of Heroes by the American College of Chest Physicians, and the Critical Care Fellowship Teacher of the Year here at Mayo Clinic. He has served as a member and vice chair and chair of the Education Committee of the American College of Chest Physicians, and leads many work groups and committees within chest as well. As you may expect, he is a frequently invited speaker around the world, sought-after mentor by many next-gen trainees, and in addition to all of this, he has authored nearly 80 peer-reviewed publications and recently took over the prestigious Mayo Clinic Academy of Educational Excellence. We are incredibly grateful for your time and your teaching. Dr. Niven, thank you so much for being here. The floor is yours.
Thanks so much, Venk, for that incredibly generous introduction. And I just have to publicly acknowledge the true treat it is to, number one, have an opportunity to spend some time with you all, and also I want to recognize Venk for just the incredibly talented leadership that he has as education chair within your department, and I think the very visible footprint that he has across the enterprise in terms of driving innovation and change when it comes to education. So anytime Venk asks me to do something, the answer is always yes. So with that, my job today is to talk to you a little bit about difficult airway management. And I am acutely aware of the fact that I am presenting to a group of individuals who most likely intubates on a more frequent basis than I do. And so I'm going to provide this perspective from the viewpoint of an intensivist, because I think when you look at the current and evolving literature when it comes to especially difficult airway management, our practices are frequently converging in more and more of a Venn diagram. And I think it's really important for us to understand our different perspectives when it comes to this common and unfortunately still very high-risk procedure. Now, I'm going to use a couple of things to start framing the approach to difficult airway management using the algorithms that we have collaboratively developed as a faculty group within the airway management program with the American College of Chest Physicians over the course of, it's frightening to say now, 17 years. I was told when I became a board member for CHEST that fiduciary relationship that you have as a board member, fiduciary responsibility, then represents a conflict of interest. So I'm going to call out Ben Sanford in the back, who's going to keep me honest in terms of the stuff that I say, and he is also a faculty member for the airway course, Ron Walls's course, and so I think there's probably some interesting perspectives to balance back and forth with that. So we're going to talk a little bit about how common difficult airways are in emergent airway management and their clinical consequences, and go back and look at the available evidence with regards to the primary failure modes that result in complications from difficult airways. We've got actually a lot of really exciting literature that's come out over the course of the last 5 years that I'm going to try to summarize briefly to make sure that we are all on the same page in terms of the most recent updates. And along the way, I think we can also highlight both some controversies and some opportunities for improvement in terms of future research. So I have always thought about difficult airway management simply defined as difficulties with either glottic visualization or tracheal intubation. And so I was a little bit disappointed when I went back to the latest Difficult Airway Society guidelines and find that that definition has now been broadened to include difficulties with face mask ventilation, the performance of the procedure of laryngoscopy, ventilation through a supraglottic airway, intubation or extubation, or really any sort of situation where you have difficulties with ventilation or oxygenation. That being said, that is probably reasonable in terms of thinking about the challenges that we face every day and the complications that unfortunately still remain relatively routine with this routine daily procedure that we perform. I've been maintaining this graph for now a number of years and perversely adding each new study specifically focused on emergent or ICU airway management, looking at the incidence of hypoxemia shown here in blue, hypotension or use of increased vasopressors in green, and cardiac arrest or death shown in yellow. And although I think if you squinch up your eyes, you can imagine the slope of this slowly decreasing a little bit over the course of the last almost 3 decades, I'm going to argue that the rate of complications here still remains unacceptable for something that we do routinely on a daily basis. And we know that overall, when we face an undifferentiated population of patients requiring emergent airway management, about 10% of those folks will have difficult airways. Most of those folks are really the individuals who suffer these complications. Now, we also have a real-world experience that's a little bit humbling. So this is the INTUBE study. The next time you talk to the good Dr. Bauer, if you want to get on his good side, you should ask him about it because he was one of the co-investigators. And this was really a snapshot of airway management procedures performed in a huge number of ICUs across the globe over the course of a discrete period of time. And what the INTUBE study demonstrated was almost half of those patients who underwent an airway management procedure during the dedicated window of time during which the study was performed experienced some major event. And again, the consistent complications that I showed in the last slide are the common complications that are described in association with difficult airway management. And in that population, over a third of those individuals did not make it out of an ICU. So I'd like to frame our conversation just briefly in terms of a case that I'm sure will be familiar to you all. So this is a 62-year-old who presents with acute hypoxemic respiratory failure due to progressive signs and symptoms of pneumonia. The patient's obese, has typical metabolic syndrome and its complications, and was placed on fairly aggressive non-invasive ventilator settings about an hour ago, and despite that, remains febrile, tachycardic, tachypnic, and is becoming more somnolent. So this is a person who looks like they're failing non-invasive ventilation, needs invasive intubation and ventilation. And, just for the sake of completeness, this is their chest x-ray. And I don't think I need to tell you that this looks bad. So The things that we face in terms of challenges in a situation like this are many. So first of all, unlike our anesthesia colleagues, most of the time when we manage airways, they are done emergently, which means we have limited time for planning and preparation. And our patients in general are not fasted. They often have full stomachs. And so with that, a greater risk of aspiration. In terms of the upper airway anatomy, many of our patients have an altered level of consciousness. And certainly when they come and see me in the ICU, it is not uncommon at all to have significant upper airway secretions and upper airway edema in these patients, many of whom have received a fair amount of intravascular crystalloid resuscitation. I think the other major factor that has been increasing in terms of both awareness and proactive management has been an open recognition of the challenges in physiology that we face on a regular basis. That snowstorm on the chest X-ray suggests that this patient has significant shunt physiology, which is driving both his hypoxemia and creating challenges in terms of potential pre-oxygenation and more rapid desaturation after apnea is induced following induction. There are individuals who talk about the shock index as a relatively reliable predictor of hypotension with induction. And then, of course, metabolic acidosis and underlying baseline ventricular dysfunction increases the risk of further hypotension, arrhythmia, or potential cardiac arrest. I presented this patient. This was a real patient with a BMI of 40 because I think that encountering patients who are a little upper Midwest size is not uncommon in our daily practice. And I think it's important to recognize the specific challenges that the obese patient presents when it comes to this procedure. So certainly because of body habitus, there are significant challenges in terms of appropriate mask ventilation due to difficulties with mask fit and potentially increased upper airway resistance from excess upper airway soft tissue. Certainly, depending on the individual and their body habitus, especially during the placement of acutely angulated blades. So we use hyperangulated glide scopes routinely in our ICU. It's sometimes difficult to get that scope in the mouth because of the excess anterior chest soft tissue. And then we certainly know that obese patients are at significant increased risk of difficult glottic visualization, both due to upper airway soft tissue and due to the risk of airway axis misalignment. We all are very well familiar with the modified Mallampati score and its correlation with greater grades, Cormack-Lehane grades. So if you have somebody who has an increased modified Mallampati score, the chances that you are going to encounter more difficulties with glottic visualization goes up. And especially with obese patients, that heavy chest wall that is part of their syndrome results in lower resting lung volumes and a decrease in FRC. And so as a result of that, you see significant increased difficulties in terms of pre-oxygenation and more rapid desaturation. And this is a classic study published now over 20 years ago, looking at the time to desaturation after induction, just demonstrating that graphically. So these were normal individuals induced in an operating room, and time from induction to desaturation using rapid sequence intubation. You can see, again, obese patients rapidly declining, and you introduce underlying cardiopulmonary disease, either acute or chronic, and you will see that time from induction to desaturation shorten even more. Probably one of the best studies looking at the contributing factors to complications during airway management is the NAP4 study. Now, although this study is relatively old, published in 2011, the methods that the authors used in this was really quite impressive. So this was a study done in the UK where they collected prospectively a registry of all airway management events done in the national health system. And as part of that publication, they broke out emergent airways performed in the emergency department and the ICU. And I don't think surprising to anybody in this room and where we practice, they found actually the majority of the airway management complications occurred in those settings. And I'm sorry, 25% of the adverse airway events occurred in these settings. And this was really the first time that the concept of human factors and challenges with teamwork and communication really came to the fore in terms of contributing factors for airway management complications. So as they systematically reviewed each of these airway management complications, what they found was failure to proactively identify high-risk patients for difficult airways, failure to clearly formulate or execute a plan as a team, or managing problems in a logical, organized manner were the major contributing failure modes. And so I'm not going to say that patients in and of themselves were blameless in this process. Certainly, the majority of patients that experienced a complication had some sort of feature that predisposed them to potential difficult airway management or complications. And I should say this is not an inclusive list. So the reason why the numbers don't add up to 100% is because there was multiple factors present in multiple patients. But education and training, poor judgment, inadequate equipment and resources, or poor communication were clearly potentially the most modifiable failure modes. So what I'm going to do is march through sort of a systematic approach to intubation, highlighting kind of the key elements that are available from the literature, are supported by common expert opinion, and also some opportunities where we still remain challenged and we don't really know the right way as we move through the preparation and pre-oxygen phase, the active intubation. When the first pass is not successful, what we do in terms of rescue oxygenation and subsequent attempts, and finally, a few words on front of neck airway. And if there's anything that I can leave you with at the end of this presentation, it's taking a systematic approach in terms of planning, preparation, and teamwork is probably the most important things that we can do on a daily basis to maximize first pass success. All right, so let's start with preparation and pre-oxygenation. And so this is a mnemonic that we put together that is just one of many out there to help think about a systematic approach to intubation that I try to do in every patient every time. So the first step is assessing the airway. The mnemonic that we use for that is it's all in your hand. So certainly if there's a history of a difficult airway in the past from a prior intubation note, that is helpful. Thinking about the anatomy and features that potentially increase the risk of a difficult airway based on that. We'll talk more about that in a minute. Neck mobility is obviously a concern if you were doing direct laryngoscopy, but less of a concern in terms of many of our video techniques. And just highlighting the fact that even though we've spent a lot of time trying to identify the best patients who anatomically have increased risk, we don't always effectively predict those high-risk airways based on that initial assessment. What I usually do when I come into a room is start pre-oxygenating immediately, because 3 to 5 minutes worth of pre-oxygenation while you're setting up your equipment, getting the team organized and preparing your patient can go a long way in terms of lengthening your time from induction to desaturation and maximizing your ability to place that endotracheal tube before the saturation drops below 88%. Preparing all of your necessary equipment, including the drugs ahead of time, is incredibly important. And then thinking about that crew resource management issue that we were talking about with the NAP4 trial, identifying the team members, reviewing the roles, primary and backup plans, and oxygen cutoffs are incredibly important so the individuals around you can anticipate the things that you are going to do. Administering medication, followed by intubation, confirmation, holding the endotracheal tube sort of rounds out the mnemonic. Now, there's lots of information out there in terms of different anatomic features that potentially predispose one to have a difficult airway in terms of glottic visualization or difficulties with endotracheal intubation. I simply highlight this meta-analysis that was published in JAMA in 2019 that really brought to the fore the upper lip bite test, which is of the available tests that are available that we have at our disposal, assuming, of course, that your patient is alert and aware to be able to try to bite their upper lip with their lower jaw, is the most predictive test in terms of identifying individuals with a difficult airway. In the ICU, we also focus on the Makocha score, which is a score that actually came out of France, looking at a series of risk factors, the greater the number of which is associated with the greater the risk of intubation. I will fully confess that I do not use the score on a regular basis because it's just hard to remember 12 things in my mind. But I think it illustrates very nicely the common elements that we associate with either an anatomic or a physiologically difficult airway. So pre-oxygenation is incredibly valuable, largely because we replace the anatomic dead space, the trachea and the central airways, with 100% oxygen, essentially functioning as an oxygen reservoir once we deliver our induction and paralytic drugs and induce apnea prior to performing our intubation attempt. The Pragmatic Critical Care Trials Group, now several years ago, published a really interesting prospective trial where they looked at the use of bag valve mask ventilation after induction and prior to intubation, what has classically been considered an absolute no-no in terms of rapid sequence induction due to the concern of aspiration. What they demonstrated in the PREVENT trial, which was published in the New England Journal, was a trend towards reduced incidence of severe hypoxemia in the group that received bag valve mask ventilation after induction and prior to intubation, and no increased risk of aspiration based on a fairly rigorous method, including both direct visualization of the upper airway and survey of the operator immediately after the procedure, and then examination of PF ratios and chest x-rays at 24 and 48 hours after the procedure. There's certainly a lot of different opinions when it comes to apneic oxygenation. So maintaining a flow of either normal or high flow oxygen after induction, and whether that reduces the risk of desaturation during intubation, at least in another single center study in the ICU, that has not been shown to be of clear benefit. What do I do with that as an individual? Well, if the device is there and in place, I usually leave it in place. But I don't spend extra time setting up, say, a high-flow nasal cannula prior to intubation simply to provide apneic oxygenation. And I think it's important to highlight the fact that there's been a lot of discussion out there in terms of the potential benefits of pre-oxygenation with either non-invasive ventilation or high flow prior to induction. And at least based on the available literature, there's not a clear signal that suggests benefit, although there are some heterogeneous signals in admittedly studies of mixed quality, looking at the potential benefit of non-invasive ventilation in obese patients or severely hypoxemic patients at baseline. Another, I think, lost art, at least in the intensive care unit for us since the advent of hyperangulated blades and video, is thinking about the importance of patient positioning to maximize glottic visualization. And this is just a few different examples of different techniques that have been described in the literature that may help improve your glottic view. So especially in that patient who is perhaps a little upper Midwest size, there is some data out there suggesting that building up the occiput so that you can align the external auditory meatus with the sternal notch might actually help align the oropharyngeal, hypopharyngeal, and laryngeal axes and improve glottic visualization. There is also data suggesting that the ramp position, where we build the patient up and shift them either in a 25 to 30 degree angle, or even in sort of a reverse Trendelenburg, as you see down here in the bottom, may help with pre-oxygenation, especially in individuals who have a robust middle section that otherwise is pushing up on your diaphragm and your lungs, and might even improve airway alignment, decreasing reflux risk. This is just an MRI sort of graphically demonstrating in an obese patient how building up the head and supporting the occiput with alignment of the external auditory meatus may help align the airway axes. And I wanted to spend just a minute talking about the prospective randomized trial that was done in the ICU looking at ramp positioning, which was actually a negative trial. So this is the summary of the results from Semler and his group on the right-hand side. You see, so this was a multi-center prospective trial looking at unselected critically ill patients who were placed either in the sniffing position or in the ramped position prior to intubation. What you can see in the red is the sniffing position in terms of the grade view in the top right corner. The operator's perception of the difficulty of intubation, easy, moderate, and difficult, and then the number of laryngoscopy attempts necessary to achieve intubation success. And again, red is the sniffing position, blue is the ramped position. And in this study, actually, the ramped position performed less well than the sniffing position in this setting. Now, I include a few graphics on the left here from a really fascinating letter to the editor that was published in Anesthesia and Analgesia in response to that and a different paper, highlighting some of the key things that we really need to think about when we're talking about positioning our patients. At a fundamental level, what we need to be thinking about in terms of airway alignment is hyperextension or extension of the atlantoaxial joint, along with flexion of the cervical spine. And really the key here, and this was really not well described in Semler's paper, is ensuring that the head is built up sufficiently to achieve those two primary goals. So I still find the ramped position helpful, especially in obese patients in the setting of really potentially difficult airways. But thinking about those concepts, I think, is really important and vital if you're going to employ this technique. We're well familiar with the induction agents that are associated with intubation, and certainly I think we use the same agents in terms of propofol, etomidate, and ketamine. I think that one of the things that I am acutely aware of in the intensive care unit setting, many of our patients are hypovolemic, many of them are in shock, and using full induction doses of these drugs will cause hypotension as a rule rather than an exception. And I have been regularly humbled when it comes to ketamine. We classically think about ketamine as a drug that provides a pressor response in terms of increased heart rate and increased blood pressure. Well, that's all well and good unless your patient is catecholamine depleted, in which case we will often see significant hypotension in that setting as well. So what is the potential solution in this situation? Dose reducing these agents is one opportunity that we can think about. The other is preemptive use of vasopressors to balance out the predictable side effects that we see with these drugs. And I should mention, because I reference him here, the article that came out of this facility looking at a 50-50 mix of propofol and ketamine as a potential solution to those challenges with hypotension that we just discussed was actually a negative trial compared head-to-head with etomidate. From a neuromuscular blockade standpoint, I would actually be curious to find out just what percentage of cases done in the emergency department now are done with succinylcholine versus rocuronium. I think across the institution, with the advent of Sugamidex, we have seen a steady migration away from succinylcholine and towards rocuronium, which I think potentially makes sense in the operating room, but maybe not so much in the intensive care unit, where we're really not looking to reverse anybody on a regular basis when they present to us with respiratory failure. The other thing, obviously, to remember for the residents in the room is the contraindications to succinylcholine, which are listed here primarily for board purposes, because I know you guys live this and breathe this every day. Other things that we think about in terms of planning and preparation in our patients prior to intubation, there are a lot of quality improvement and poorly controlled studies that have discussed the potential value of fluid loading over the course of the years. We've now looked at this in 2 large prospective trials in the intensive care unit and found no benefit for fluid loading in the Prepare 1 and the Prepare 2 trials. And so I've stopped doing this on a routine basis in my inductions. We know, really based on emergency medicine literature, that rapid sequence induction is likely the best approach to maximize first pass success in at least the undifferentiated population of patients who present to us on an ongoing basis. But again, one of the things that comes with that is a risk of hypotension, given the fact that you don't know the underlying circumstances and situation of the patient that you're facing. And so really, based on some very nice quality improvement work that Paul Mayo and his group at Long Island Jewish did back over 10 years ago, I think there's been a slow but steady creep towards preemptive vasopressor use in this setting, anticipating and balancing the effects of hypotension that we see with many of our induction agents. And that's especially important in the setting of distributive or cardiogenic shock, right ventricular failure, or aortic stenosis. So let's talk a little bit about intubation. So one of the things that we have really pushed as an airway group has really been highlighting the fact that prevention of hypoxemia is perhaps just as important as placing that definitive airway in an acutely ill patient presenting to the ICU or the emergency department setting. And so obviously, if somebody is crashing and has very low oxygen saturations to begin with, we've got to move very quickly. And that automatically sort of moves us into a sort of a failed airway algorithm where we're focusing on restoring oxygenation first, stabilizing the situation, and then getting the endotracheal tube in. I think something that is largely a data-free zone in the intensive care unit is the use of awake intubation in individuals where you have time and clearly have risk factors for complications and a difficult airway. And this is something that I think we see practiced highly variably based on the provider and the setting in our intensive care units, and a clear opportunity for improvement, both in defining the right patient populations, the right upper airway topicalization, the right medications to use as part of that process. And then typically we are using fiber optic intubation in this situation because as pulmonologists, we feel a little bit more comfortable that way. For the vast majority of the rest of the individuals, really where we think we can get an airway, we're going to put that person to sleep and intubate them in one way, shape, or form. And this is really where we have a very exciting development with the device trial that was just published a little bit over a month ago now, online first in the New England Journal of Medicine. So this was a large prospective randomized trial looking at video laryngoscopy versus direct laryngoscopy and the rate of first pass success in an unselected population of patients presenting to either the emergency department or the intensive care unit. Now, you guys did much better in terms of overall recruitment. Again, probably because you see a lot more folks who require intubation than we do on an ongoing basis. We then receive them from you. So 70% of these procedures were done in the emergency department. And not surprisingly, the major indications for intubation were altered mental status and respiratory failure. What the device trial showed was a significant increased incidence in terms of first pass success when a video laryngoscope was used. It's important to highlight that the vast majority of the video laryngoscope procedures were performed with a more traditional Stort CMAC, McGrath Mac, or GlideScope Mac blade. And the complication rates were relatively similar between the two arms of the study. A couple of details that I think are worth mentioning as an editorial comment. So on the left-hand side, you see the rates of hypoxemia, hypotension, new or increased vasopressor use, and cardiac arrest. And I will say, compared to those other data that I showed to you early on in the presentation, the performance of this group overall was quite good. So the major signal in terms of complications was really seen in the new or increased vasopressor group. And I honestly don't know whether that's a complication or a shift in practice. I've already reflected our biases up in the intensive care unit. But I think the other thing that's really important to highlight in the forest plot here is that a lot of the signal that drove the positive outcome here for video laryngoscopy was really driven by operators with lower levels of experience and greater degrees of exposure to video laryngoscopy. So I think that there's ample data to suggest that as time has gone on in our training programs, we focused more and more on video. As somebody who supervises procedures on a regular basis, I like it when I see what my trainee is doing, as opposed to dancing around in the corner and asking, what are you seeing? And I think that over time, that has led to greater and greater familiarity with VL. And so here, I think this may be the first sign of a tide that is changing for a new generation of airway managers. I want to spend a few minutes talking about the benefits of bougie use, which, again, this group probably uses bougies a little bit more commonly than we use in the intensive care unit. The bougie has really been demonstrated amply as an incredibly valuable tool when you have difficulties with glottic visualization or difficulties in terms of tracheal intubation, to serve as a guide to find your way underneath the epiglottis into the trachea and then railroading that endotracheal tube over that. And really, there's lots of data to suggest a high rate of success in patients who have initial challenges with first pass success using the bougie as an adjunct in that setting. Now, Brian Driver and the folks up at Hennepin County published the BEAM trial back in 2018, which was really a very provocative study suggesting that we should consider transitioning to the use of a bougie as a routine tool for first pass intubation, sort of cannibalizing a concept that has been prevalent in the pre-hospital setting for some time and bringing it into the hospital. I show this data not because it's new, but just really to highlight the tremendously high rate of first pass success that the folks at Hennepin County were able to demonstrate using a bougie first pass success rate, regardless of the grade of difficulty in terms of Cormack and Lehane grading. Consistently, statistically significantly higher in every grade except for grade 4. And again, just to highlight here, the vast majority of the time up in Hennepin County, they use a CMAC device, although they don't always use the screen with that. Now, based on that, the Pragmatic Critical Care Trials Group actually performed a very similar trial in their collaborative network of 11 institutions, only one of which used the bougie routinely for first intubation attempts prior to this trial. And what was striking with the bougie trial that was published in JAMA in 2021 was a completely different result. And so here, what we found was that there was no difference whatsoever in terms of the rate of first pass success. And you can see here, based on the grade, again, no difference between bougie first versus endotracheal tube and stylet. So what's going on here? Well, this is my editorial comment in terms of what I think the major differences were between the BEAM and the bougie trial, and potentially some lessons that we can take and translate into our clinical practice. So we know at Hennepin County that they use bougies all the time for their first pass. And as a result, their trainees, and by the way, in both of these studies, the majority of the airways were placed by trainees, have lots and lots of training and practice. When you look at the bougie trial, although their operators, again, were trainees, but relatively experienced with a median frequency of 60 intubations prior to enrollment in this study, their experience with bougies was substantially less. So all of these individuals had a median of 10 bougie assisted intubations. And in terms of the training that they received for this trial, that was largely left to the site, either the investigator or to a video that was provided during that study. So not surprisingly, training and experience potentially drives greater success. I think that's also illustrated by the fact that when you look at the amount of time that it took to place the endotracheal tube in BEAM versus bougie, it was much faster in the BEAM trial, almost 2 minutes in the bougie trial, which kind of raises a lot of concerns in terms of the team and communication and practice in those varied institutions. Certainly, when we look at risk factors for obesity, difficult airway characteristics, and difficult views, not a lot of difference overall between these different trials. But it also begs the question of what really the role of a hyperangulated blade is when you have a bougie at your disposal. And I think that is a question that still remains to be answered. The last thing, and again, I hate to beat this drum over and over, but it really bothers me to think about a routine procedure that we perform on a regular basis being associated with over a 10% risk of severe hypoxemia and oxygen saturation less than 80%, or cardiovascular collapse and arrest. And clearly, there's opportunities for improvement regardless of the technique that we choose here. Now, we spent a lot of time talking about the available evidence when it comes to our first pass attempt for intubation. But what happens when the endotracheal tube doesn't go in the first time? Well, rescue oxygenation really highlights the fact that in that setting, our priority must shift to preserve adequate oxygenation and ventilation first, and at the same time, continue to troubleshoot the situation to get a definitive airway in place. So typically in this situation, we think about bag valve mask ventilation first. And if we can stabilize the situation in terms of adequate oxygenation and ventilation, then we have time to think about the varied airway tools at our disposal. One technique that's been popularized by many systems, the VA being one of them, is the vortex approach, thinking about mask ventilation, endotracheal intubation, and extraglottic airways as the three sort of categories of tools at our disposal. And as we move through our sequential intubation attempts, thinking about varying something in that technique, be it manipulating the patient, the larynx, the device, trying different adjuncts, different sizes, improving oxygen flow and muscle tone or relaxing muscle tone as the major tools that we have at our disposal. The concept with the vortex approach, of course, is that as time goes on and repeated attempts continue, the patient starts circling along that vortex, moving closer and closer to the center and a front of neck airway. Certainly, if we can't reestablish ventilation and oxygenation after our first attempts, then really our algorithm is fairly simple. We move very rapidly to attempting restoration of ventilation and oxygenation with an extraglottic airway. And if that is unsuccessful, we move on to cricothyroidotomy. Now, I feel a little sheepish talking about extraglottic airways to this group because, again, you guys deal with these a whole lot more than I do, especially extraglottic airways that are placed in the pre-hospital setting, which is really where the majority of the data is. And I simply bring to you these two very large prospective studies that have been published over the course of the last several years, looking at the effectiveness of extraglottic airway placement versus endotracheal intubation in the field, and showing in terms of the rates of first pass success, they're much higher with the use of a laryngeal tube and supraglottic device, with significant associated benefits in terms of return of circulation, hospital survival, and neurologic outcomes. I think the thing that was striking to me reading these articles was a follow-on study that I apologize I didn't include on this slide that Driver published in the Annals of Emergency Medicine last year that looked at the most common most common action on the part of an emergency medicine physician after a patient with an extraglottic device arrives in the emergency department. And in over 90% of those patients, they took the extraglottic airway out and intubated primarily. It's a very different situation to what we face in the intensive care unit, because when we place an extraglottic airway, we're usually up a creek without a paddle and looking for something to stabilize the situation. And once we have stabilized the situation in terms of restoring ventilation and oxygenation, we're going to take a very systematic approach in terms of fiber optic intubation through that device, either with a tube exchanger or primarily with a bronchoscope. And we'll usually do that in the operating room with a surgical airway manager available. So if we need a front of neck airway, we'll be able to do it rapidly. So finally, a word or two about front of neck airways, which I think any airway talk has to include, because if you manage an airway, you have to be prepared to potentially perform a surgical airway if things go wrong. Now, As you might expect, the data in this area is not particularly robust. So we certainly know that a 4-step surgical technique is most rapid. We make an incision, punch through the membrane, secure the trachea, and advance the the cric tube. For individuals who are not super comfortable cutting the neck, which certainly I would put all of my internal medicine pulmonary critical care colleagues, there is a bougie assisted approach using a modified and also a modified Seldinger technique that translates into a greater frequency of first pass success. It just takes longer, which may or may not be okay in this emergency situation. Certainly, doing a cric blindly increases the risks of esophageal perforation, subcutaneous emphysema if that tube gets placed in a blind track, and then risks of bleeding. But this can be a potential life-saving intervention, especially in an era where we are dependent more and more on glide scopes, which still can be challenged in terms of situations of upper airway soilage or marked anatomic disruption. The last things that I'd like to leave you with, we've spent a lot of time talking about planning, intubation strategies, and the data behind it, both in terms of primary and rescue strategies. There's certainly plenty of data out there, and I'm not going to spend a lot of time on that. Talking about best teamwork approaches in terms of shared crew resource management, shared situational awareness, and the communication tactics that go along with that. One thing that I will spend just a minute on is airway checklists, since that's something that has been studied and is something that certainly has been popularized as a method to minimize judgment and reduce errors of omission. So this has been studied again prospectively in the intensive care unit. And unfortunately, in the one study that has been done looking at this, there was no significant benefit in terms of the use of a checklist during ICU intubations. Now, one of the challenges of this trial was the investigators started off using a modified Delphi approach to identify what they felt were the vital steps to intubation that should be performed every time. This, again, was performed in major academic medical centers. You would assume that the processes associated with airway management should be pretty good in that setting. And so, arguably, if we select domains that should be done every time and are probably done consistently every time, the vast majority of cases, we're not going to see a signal when it comes to checklists. And so we actually wrote a letter to the editor in response to this to highlight the fact that this trial really doesn't suggest that we should throw checklists out when it comes to airway management, but really just marks the beginning of the journey because the most important thing is to identify the key points that must be done every time, perhaps simplifying even further the checklist of items that you see here. So with that, I'd like to wrap things up and leave just a few minutes for questions. I think what I'd like to leave the group with as a take-home point is the fact that we deal with emergent airways all the time, and they are high risk because of both anatomic and physiologic considerations that we have to factor in our planning and preparation, because failure to plan is really planning to fail. And I think I've showed you ample data that right now our failure rates in terms of complications remain unacceptably high. Based on the available evidence to date right now, I'm still reaching for a video laryngoscope in the vast majority of the patients that I see in the ICU. And I still really like using a bougie as my primary rescue technique if I have inadequate glottic visualization or if I have difficulty passing the tube. And when those first pass attempts fail, really, I think the most important thing that we need to guard against is task fixation, focusing on placing that tube, and remind ourselves that oxygenation rather than intubation is our first priority, making sure that we've got help available, and making sure that we don't keep on trying to do the same thing over and over, right? Because the definition of stupidity is doing the same thing over and over and expecting a different result. And because we are all faced with situations where we have a crash airway, where we can't ventilate and we can't oxygenate, we all have to make sure that we think about extraglottic airways early. That's probably a greater challenge in the ICU than it is in the emergency department. And we all need to be comfortable potentially managing that patient with a front and neck airway if everything else fails. And with that, I'll thank everybody for their attention and love to open it up for a few questions and comments.
Alex, thank you. That was a wonderful talk. I have two comments and there's questions within them. Supraglottic airways, we are not immune to having disasters with them. We've experienced those. I had one with a king after when they were told they were safe. We were one of the earliest complications, right? One thing to think about is, as you alluded to, in the ICU, it's been in there for a while or it's failed. And when someone's put it in, it's usually there for a reason. There is edema that does occur. These can be very, very dicey airways. And these are not ones to sleep on. As Francisco knows, I love the bougie. You could not get enough bougie. There's one other thing you said that I thought was really, really important. And now I'm old and I forgot. But the whole thing about task. One of the benefits we have, one of the beauties of the resuscitation model that we have, and is kind of the Mayo model of team care, is you have someone in a resuscitation, you have someone, the proceduralist, doing the airway, and then someone who's back away managing the hemodynamics. And that's really important. And that's something I hope we never lose. And as residents, you go in the community, you won't have that. And it's very, very easy to get fixated on, I have to get the airway, I have to get the line, and to lose sight of everything else. Because in order to get in that deep space to focus and get something done, you will lose sight of the bigger picture. And it's not that you did anything wrong. It's just how human brains are built, right? You can't multitask. All you can do is task switch, regardless of what anybody tells you. So if you're in that situation, somebody has to be keeping an eye on the bigger picture.
Yeah, completely agree with all those statements. I think that it's important to highlight the fact the extraglottic airway is not a definitive airway. And so if there was an exciting situation that put it there, then it's going to be exciting once it comes out if you don't manage that preemptively.
Thanks, Alex. That was so great and so clear and well organized. So thank you for that. My question is, given that we're in a training institution and given that our patients are typically 1 to 2 Midwestern units, would you say that all trainees should just, with the first pass, use the bougie given the success of the beam trial? Like they should just always just use a bougie no matter what? And that way, when they get to the harder airways, they have that down at least?
Yeah, I think that's a very provocative question. And I think that although I'm not sure if I can necessarily say that the data supports, a clear-cut statement that we should be using a bougie every single time we manage an airway. I think that I teased Brian about this. We had him and Matt for critical care grand rounds for Journal Club. And I asked him basically what was the secret sauce when it comes to Hennepin County and their outstanding outcomes in terms of first pass success. And I thought that his response was really very thoughtful, that really all the procedural tools that we have for airway management are just tools. It's the culture and the organization and the team that really drives their success. And I think part of that requires adequate training and experience in bougie management. So I think to back into that answer for you, I think it's more than just pushing the bougie with every intubation. I think it's pushing a well-organized airway management program, teaching those tools that people can either propagate if they stay here as consultants or carry with them to so many other areas across the country and the world that clearly have great opportunities for improvement in terms of airway management for emergent intubations. And I think we need to be skilled with the tools that we choose to use. And the bougie is an essential tool that we should be using. So how's that for a mealy mouthed answer?
Okay.
Sarah.
I like how you pointed out the half dose etomidate for hemodynamic support. We have colleagues in various specialties in this institution that have strong opinions about etomidate and the adrenal suppression. Do you guys in the critical care in the ICU, do you tend to, as a group, have strong hate or love for etomidate versus ketamine, or do you guys not have a strong opinion?
So I think that we have moved past the concern about suppression of adrenal steroidogenesis when it comes to etomidate. So I'm forgetting the name of the trial, but it was published in the Lancet now a number of years ago, large multi-center prospective trial randomizing patients to RSI using either etomidate or ketamine. And admittedly, that was full dose. And showed they actually drew cortisol levels as part of that trial and clearly demonstrated a statistically significant increase in terms of steroidogenesis, but really no difference in terms of adverse patient outcomes. And I think as a result, I certainly have moved past that. And although you'll still hear those words echoed in the hallway from time to time, I don't think it's a significant clinical concern. I think the bigger question that remains in my mind, and I hate to keep on quoting those guys up north because they're going to get swelled heads, but they published a really interesting study about recall after airway management in the emergency department, demonstrating a kind of frightening instance of some degree of patient recall and associated psychiatric complications with those procedures. And so, I can glibly say dose reduce 25 to 50%. That's going to keep the hemodynamics better. But how much is enough without reducing too much? I don't know the answer to that question. And I think that is a fruitful area for future research. I thought there was another hand somewhere.
Well, I was just wanted to say, answering to Neha, I got a paper accepted last month in Annals of Emergency Medicine. It's a systematic review with 10,000 patients with bougie. And what we showed was that bougie was better for first pass success, particularly people with like worse airway, like airways that are with worse views. So what we ended up concluding with, again, 10,000 patients was that if you use it all the time when you really need it, you're going to be proficient at it.
Right.
Versus if you only use it for rescue, then you're not as good. And that shows with the slide that you show with how long it takes with bougie when you use it all the time versus when bougie when you use it some of the time.
So for the trainee, should we be using this more routinely? I think the answer is yes.
Yeah. So I missed that reference. I'm sorry. I got to get it from you.
Yes, I'll send it.
I
I think the paper you're talking about is in Nature. I'll send it out. It was ketamine versus etomidate, large study. There's no difference in outcome. I think it was a big deal.
Yeah.
So I can send there. Thank you.
Ben, maybe last word. I know we're running over.
Alex, thanks for this is a wonderful talk. You know me well, and I love thinking and talking about airway stuff. So this was absolutely excellent. I think the question that has been brought up about training and use of these devices is really one that, as a trainee and also as the educators, we have to be thoughtful about, because we know that use of video laryngoscopy is superior to use of direct laryngoscopy. The data is clear. And when I exited residency, my mentor, who is an airway guy as well, said, you really should be consenting patients with the following verbiage if you're going to use a direct laryngoscope. We have a better tool that's shown to have a far improved chance of success and lower complications, but I'm going to use this direct laryngoscope. And he kind of equated it to doing a landmark guided IJ versus an ultrasound guided IJ. Like we would never do that anymore. But the challenge is the video's all well and good until you have an airway full of vomit or blood or, what have you. And so there are times when you need to be proficient and, expert at DL. And so using these tools in a training setting where you are practicing your DL chops while still having the video laryngoscope in the mouth in the event that something bad goes wrong, so that Dr. Niven can turn the screen around and say, okay, just look here, we can move forward. And I think that's probably the sweet spot. And the same thing with bougie use. You don't want to always only use a bougie, because you do want to know how that tube maneuvers in the absence of a bougie. And the same thing with what you brought up about awake intubation. I think that's such a very important concept. There are lots of patients that I think we should be considering awake intubations in, who we know have difficult airway risk factors. And in emergency medicine, we are very, very easy to knee-jerk right to using RSI because it's what we do. And it's only in the direst of circumstances where the tongue is plastered to the roof of the mouth and sticking halfway out that we decide to do awake fiber optic intubation. But there's probably a middle ground there where we need to be thinking about, well, this obese patient who really can't open his mouth very much, should we be topicalizing and doing this awake? And I think the answer is yes. And so you just bring up so many really thought-provoking things. And so thanks for a wonderful, wonderful grand rounds.
Can't say anything better than what he just said. So with that, I'll close. Thanks so much, everybody.
That was phenomenal, Alex. Thank you so much. I can't wait for us to get to work together on another project in the future. Audience, you heard some great reactions from some voices we have already heard on our show, including at the end, Dr. Ben Sandifer. If you have, quote, air hunger, end quote, for more airway content, check out his amazing discussion about angioedema and the awake tracheal intubation in Season 1, Chapter 13 of this show. That chapter continues to be among the most lauded shows we have ever put forth. Well, that wraps up our September content. We have some fascinating stuff in the works for October, so please join Alex Finch and me on October 1st. In honor of Halloween coming, we will aim to shed light on the scary parts of emergency care and provide sweet candy nuggets of knowledge. Until then, let us be, as Dr. Charles H. Mayo described in 1931, quote, "If we excel in anything, it is in our capacity for translating idealism into action."
The Always On EM Podcast.
Emergency Medicine Grand Rounds.